So this is entitled Disparities in the Surgical Workforce, Are Institutions Ready for Diversity? So here are our objectives. So we're gonna really evaluate diversity within the workforce, looking at the etiologies of the leaky pipeline and institutional readiness for diversity, then move into strategies for managing microaggressions and becoming an upstander and achieving active allyship. And then we'll end the talk with describing strategies for increasing DEI and anti-racism within the House of State. I have no disclosures. Okay, so this is the changing face of America. So in 1950, we were about a country that was about 87% Caucasian. But by 2050, that number will drop to about 47%. So we will be a majority country in just a few years. And the U.S. Census really, identified that we're more racially and ethnically diverse compared to even 2010. And there are many, many types of diversity seen and unseen. And the question is, why is DEI important? And so I love this quote, I use it often, that diversity is at the highest levels of leadership at academic health centers really contributes critical and innovative viewpoints and organizational level changes that really ensure excellent patient care, which is what it's about, groundbreaking research, and really serves as a model for health professions education. And so the fundamental question really are we training a workforce that's not only reflective of the diverse patient population that we serve, but one with cultural humility and free from implicit biases? And does our leadership have cultural humility, free from implicit biases, and reflective of the diverse patient population to whom they serve? We're going to take some moments to really kind of go through the data. So here is the pipeline to academic surgical leadership, beginning in medical school all the way up to the highest of leadership in the chair and dean role, and really understanding the definition of URIM being the racial and ethnic populations that are underrepresented in the medical profession relative to their numbers in the general population. So I'm looking first at medical students. This is data from the AAMC. Out of nearly 20,000 medical students, about 38 were American Indian in 2018, about 4,300 were Asians, about 1,300 were Black students, about 1,000 were Hispanic, 9 were Native Hawaiian, and about 10,800 or 11,000 were Caucasian. And so if you look at the US Census, which is on the right here, and looking at comparing the representation within medical school, you can see that there are some disparities, right? So 60% of the census is Caucasian, about 54% represented in medical school, 5.9% in the US are represented by Asians, and 21 or 22% in medical school. When you look at Blacks and Hispanics, the numbers are quite different, right? So 22% Hispanics in the US population versus about 5.3% in medical school. And that number is about 13% for African Americans and 6% in medical school. And so we wanted to look first at residency, really to evaluate the demographic trend of general surgery residency applicants, matriculants, and graduates from 2005 to 2018. And what we found is of the 25,000 residents within the US, about 10.1% were represented by underrepresented minorities. And so for URIMs, the proportion of applicants, matriculants, and graduates really remained significantly low and unchanged over that time period, while the attrition remained significantly higher for underrepresented minorities, about 3.6% compared to 2.6% for Caucasians and 2.9% for Asians. And then we wanted to specifically look at African American trainees, and we looked at Black women and Black men trainees within our residency programs, again, looking at applicants, matriculates, and graduates over time, with the idea of eliminating disparities to ultimately improve patient outcomes. And what we found is that the matriculation and graduation rate for Black women remained unchanged, about 2.4%, 2.5%. But there was a decreased matriculation of African American men from 3% to 2.4%, and graduation also decreased from 4.3% to 2.7%. So among nearly 18,000 male general surgery graduates, 3.8% were represented by Black men. And when you look at that graduation rate over time, there was a significant decline, which occurred at a yearly rate of about 0.1%. And among African American female graduates, 2.5 were represented, and that rate remained low and unchanged over time. So this generated a lot of, or some media, really asking that question, wait, we're not really representing, Black trainees, particularly Black men, in our residency programs. And so the next question, looking in the pipeline, as we would expect, as it continues to leak a little bit, well, what are we doing with our fellows? Are we training, fellows? And so we presented this at most recently at the Western Surgical Association, looking at underrepresented minorities in surgical fellowships. And in looking at pediatric surgery, colorectal surgery, surdonc, thoracic surgery, and vascular surgery, the percentages were low as we would expect: 13.4% for applicants, 9.1% for matriculates, and 9.1% for graduates. But when you stratified by both race and gender, those numbers were significantly lower for underrepresented minorities, with 2.4% of graduates. And so if you look specifically at URIM females, there was no statistically significant change in the matriculates or graduates over time, but we saw a decrease for underrepresented minority males. And that trend was particularly evident among thoracic surgery fellowships. And so looking specifically at surgical critical care, Dr. Carlo Pugh was an author on this particular paper. We saw a decline in the training of Black and Hispanic surgeons. That disparity really persisted within this fellowship. And again, turning our attention specifically to African American and Black trainees, again looking at the disparities, you can see the single-digit numbers for both male graduates and female graduates in the various surgical subspecialties. So why are we seeing a decline in the graduation of underrepresented minority trainees? So this is from the ACGME, and this is dismissal data by specialty. And at the bottom is surgery, and green represents Black trainees. And so African American Black trainees are dismissed 6 times the rate of their white counterparts. And so, this got some. This wasn't from this data, but why is the attrition rate so much higher for African American trainees? So this recently came out in JAMA Surgery, and it looked at the attrition rate among surgical subspecialties. And Black and African American residents are at a disproportionate risk for attrition and unattended attrition compared with all other residents. So they're saying, attrition being all-cause withdrawals, dismissals, transfers, unintended attrition, withdrawals, dismissals, and transfers, except for changing career paths. And orthopedic surgery really has the highest rate of attrition, with a relative risk of 3.8, and unintended attrition at 7.2 for African American trainees. And so Hughes and colleagues published this in JAMA Surgery in 20, trying to understand the national prevalence and the sources of discrimination based on race and ethnicity in the US, to look at factors associated with discrimination, and to then assess its association with resident wellness. And so if you look at the prevalence of discrimination, it was highest among African Americans at 70%. Next is 45% by Asians, and Hispanics at about 25%. And the sources of discrimination really are about different standards of evaluation, denied opportunities, being mistaken for a non-physician, slurs, hurtful comments, feeling socially isolated, or being mistaken for a person of the same race. So if you looked at, being African American, you were nearly 20 times more likely to experience discrimination, 6 times more likely if you were Asian. And so this really was not surprising. The numbers were high in that now you have residents are reporting higher rates of burnout, thoughts of attrition, and unfortunately suicidal thoughts because of this. And so we need to focus on creating an inclusive environment for our trainees that is free from discrimination and bias, that's really more reflective of an environment rooted in respect, equity, and support, where there's strong mentorship, sponsorship, and psychological safety are celebrated and considered the norm, so that retention is high and attrition is low. And so that gets us into microaggressions, right? So these brief, verbal, environmental, unintentional or intentional comments targeted at a particular group. And it's often described as sort of the death by 1,000 cuts that can be very harmful and have psychological effects on the targeted individual. And so the microaggressions are really broken down into racial microaggressions, microassaults, micro insults, micro invalidations, and environmental microaggressions. And it can be, conscious and intentional. It could be verbal, nonverbal, and it can nullify the thoughts and feelings of a person of color. So this came out in JAX, really looking at the thematic nature of microaggression, really identifying some of the common microaggressions experienced in our workforce by racial, ethnic, minority surgeons. You can see the type of aggressions is on the left, and you kind of get the example, and you get to, the micro assaults are pretty obvious, right? But it's the micro insults. People are, saying comments like, how did you get, can you get me my tray, or you're walking in with your white coat and your name badge, and you're being mistaken for somebody other than a physician. People are questioning your intelligence, or asking about your first language, this myth of meritocracy, and then environmental, right? At least this is the comment. At least once every time at the conference, I look around the room and I realize I'm the only person of color in this room, and just by the basis of that, I feel different. And so this study, this survey, this foreigner not belonging, you're more likely to experience that by, for our Asian Hispanic colleagues. If you were a Black surgeon, you were more likely to feel the environmental microaggression of criminality and visibility, low achieving, undesirable. And so how do we manage this? What are the strategies for managing microaggressions and really becoming an upstander to achieve active allyship? And so the upstander is somebody who takes action when they see an act of intolerance, who speaks or acts in support of an individual by intervening on behalf of that person who is attacked or bullied, who actively works to create an anti-oppressive world. And so, the bystander, which is just the opposite, right, is, you're witnessing a bias, you're witnessing a microaggression or overt racism, and you just remain silent. And as Archbishop Tutu said, if you are neutral in situations of injustice, you have chosen the side of the oppressor. And so how do you respond? A lot of people say, I don't know what to say, you're frozen in the moment. And so whether you're an observer, the target, or the unintentional perpetrator, you just don't know what to do. And you may be frozen, or you feel sort of defensive. And so here are some strategies that you can use to be an upstander. So GRIT, so gather, restate, inquire, talk it out framework. So this was a method that was developed to address microaggressions. And so G stands for gather your thoughts. Pause, don't react with anger, decide if it's an appropriate time or place to address the perceived aggression. Restate it. So restate the comment, ask the speaker to restate their comment and allow the person to clarify or realize the potential negative impact of the words or actions. And then inquire, dig deeper, seek clarification. Please help me understand what you mean by that statement. That be non-judgmental and address the comment or the action rather than making it about the person. T stands for talk it out. Discuss the potential impact on others and your personal perception. So in my experience, that comment may perpetuate negative stereotypes. So the key points really are separate the person from the comment, avoid personal attacks, and instead really consider focusing on the remark and how that is being perceived. And so if you witness this microaggression, don't speak for the affected person, like you're hurting his or her feelings, but consider this is how I perceive the comment. Open the front door is another strategy. So observe, describe clearly and succinctly what you see happening, and state what you think about it, feel, express your feelings about the situation and desire, really assert what you would like to happen. So for example, underrepresented minority faculty members being asked to represent their entire ethnic group You might say, let's pause for a moment. I notice that there seems to be an expectation that an individual can speak for an entire group. I think we need to resist this temptation. It's too much to ask of anyone to speak for an entire community. I feel uncomfortable with this request, and I'd like for us to only ask others to speak for themselves. Or I notice that some people are interrupting others while they're speaking. I think we need to actively listen to all of our ideas so that we can learn from one another and maintain norms of respect at our meeting. I feel uncomfortable moving forward with the discussion. Can we please speak one at a time and give others the chance to share their thoughts? The third strategy is action. Ask clarifying questions, come from curiosity and not judgment. Tell what you observed in a factual manner, impact exploration. Own your own thoughts and feelings around a situation, and next steps request appropriate action be taken. I want to make sure I understand what you were saying. Were you saying X? Can you tell me what you were hoping to communicate from that comment? Can you help me understand what you meant by that? I noticed that. What do you think people think when they hear that type of comment? What impact do you think that comment could have? Where I hear your comment, I think or feel, or in my experience, that comment can perpetuate negative stereotypes and assumptions. I would like to think that is not your intent. I encourage you to revisit your view on X, or I'd appreciate it if you would consider using a different term because it's inconsistent with our equity and inclusion. XYZ is I feel uncomfortable when I hear comments about Dr. Smith because he is not here to defend himself. And finally, interrupt, question, educate, echo. Excuse me, can you clarify the question? What made you say that? Educate, let me share my personal experience. And echo, thank you for saying something, or I agree with that, let me add. And so this is all about allyship. So allyship is an active process. It's an active and consistent practice of using power and privilege to achieve equity and inclusion, while really holding ourselves accountable to marginalized people's needs. And so being an active ally is in the face of being a witness to bias and microaggressions, you have the moral courage to intervene and take action in the moment, because silence is complicity. So part of being an ally is really recognizing your privilege. It's really important that you educate yourself. So everyone should have a fundamental understanding of the history of structural racism in this country, to not only value the importance of diversity, equity, and inclusion, anti-racism, and social justice, but to work collectively to dismantle the systemic inequities to ultimately achieve the best outcomes for all of our patients. Understand the common terms of implicit bias, cultural humility, and intersectionality. So implicit bias really, we have unconscious attitudes towards others. It runs counter to your conscious expressed beliefs. And few people will express overtly explicit racist views, but their actions really reflect their bias. So the example really is, giving less pain medication to your African-American colleagues or patients. So you can be explicitly unbiased, but implicitly biased. And I know we had the term cultural competence, but it's really sort of changed to cultural humility and sensitivity, where you have a true understanding of the complexities of identities, and that because you're never going to be truly, fully competent about an evolving and dynamic nature of a patient's experience, that's really shifting to this intersecting identities of ongoing curiosity rather than an endpoint. So competency really kind of reflects an endpoint as opposed to this dynamic nature. And so to have sort of multicultural humility and sensitivity, you have to have a basic understanding of your own culture. It's difficult to understand someone else's culture if you aren't familiar with your own. You have a willingness to learn about cultural practices and worldviews of others, and really have a positive attitude about cultural differences and the readiness to accept and respect those differences. And intersectionality is really about different identities, right? So it's an intersection of interconnectedness of identities. And looking at, sometimes we tend to treat race and gender as mutually exclusive categories of an experience. but not recognizing that, so for example, as a Black woman, you're both Black and female, and you're subject to discrimination on the basis of race, ethnicity, gender, and the possibility of the combination of the two. And so cultural patterns of discrimination and subsequent inequities really are interlocking and really can't be separated on the basis of only one aspect of identity or experience. And so you're having an intersectional lens, not only in how you take care of patients, but in your research questions. It's been really important to understand how multiple identity experiences impact different populations. So check in and speak up as an ally. Understand, again, that silence is complicit. Hire, promote, sponsor, and support underrepresented minority trainees, faculty. I love this. I was very excited to see this, because I know it's gotten a lot of attention, but you need to really be intentional in the recruitment and retention of underrepresented minority trainees, faculties, and your leaders. So in looking at faculties, minorities and women remain grossly underrepresented in academic medicine, and we saw the data as medical students, residents, fellows. Black faculties have really shown the least progress over the last 12 years. And we see the disparity greatest at the highest level, so professor, chair, and dean. Black assistant professors have had lower tenure promotion rates across all specialties, and underrepresented minority surgeons are less likely to remain in academia. And so this was a position paper from the Society of Black Academic Surgeons looking at the prevalence of women surgeons among US medical school faculty, stratified by race and gender. And we also looked at the number of NIH grants awarded to underrepresented minorities, particularly Black women surgeon scientists, over the last 2 decades. And so in looking specifically at funding, Black applicants remain about 10 percentage points less likely than whites to be awarded NIH research funding. And topic choice alone, accounts to about 20% of the funding gap, as Black applicants are more likely to propose research topics that are less likely to be funded. And so if you look at African-American applicants in the red and white applicants in the blue, Black applicants, their applications are less likely to even be discussed. And if discussed, they are less likely to have a higher impact score to be funded. And so we looked at the NIH funding over from 1973 to 2017. And of the nearly 16,000 funded applications, you can see the gender breakdown between females and males. About 1,700 went to females, about 13,000 went to men. So this is what it looks like visually. So the blue line is the total number of applicants. The purple line is the number of female applicants that have gotten funded. And the yellow line is the number of male applicants that were actually funded. And so in breaking that down by race and ethnicity, about 500 of the 16,000 funded applications were awarded to underrepresented minorities. 340 went to Hispanic surgeons. About 273 went to Black surgeons. And if you look at, again, intersectional lens, if you look at Black women, about 31 received funding between 1998 and 2017. And of the 80 submitted applications, there were fewer than 12 Black female surgeons awarded funding over the 20-year period. So this came out in JAMA Surgery by Lewitt, who examined the associations between NIH funding for surgeon scientists and sex and race ethnicity in 2019. And as you can see, in 2019, no Black woman or Hispanic woman or female orthopedists received R01 equivalent grants in the entire year. Turning our attention back to faculty, so medical school faculty. Here's the breakdown of the nearly 16,000 medical school faculty. About 552 were Asian, 82 were Hispanic, African American. And then if you look at it by rank, you can see that of the 3,500 professors of surgery, 51 were Asian women, 5 were Hispanic women, 10 were African American women, and about 318 were Caucasian women. And at the time of this publication, out of the 337 chairs of surgery, you can see the single digits. 2 were Asian women, 2 were Hispanic women, 0 African American women, and about 12 And that changed. So after the sort of big zero came out, we saw some changes in our field. So 2021 was a big year as far as shattering glass ceilings. Dr. Patricia Turner became executive director of the college. Dr. K. Marie King was the first African American chair of surgery at Albany. Dr. Andrea Hayes, now Dixon, is chair of surgery at Howard, now dean of surgery at Howard. Dr. Karen Gibbs is chair of surgery at Yale Bridgeport. And so we had an opportunity to talk to each and every one of them, and talked about their journeys, talked about their experiences, and then had a conversation with African American, a medical student, a fellow, and a junior faculty, and Dr. Kyler Pugh was actually part of this as well. It was a fascinating perspective on what it meant to see them ascend to this, being chair and being executive director of the college. So the data clearly shows, from medical school to residency to faculties to full professor and chair, there are clear inequities, right? We are not training a diverse workforce. And for those who do get trained, we're not promoting or advancing underrepresented minority faculty to leadership. And so, I love this quote by Dr. Tim Eberlein, because it really kind of hits home to the why. Why are we all focused on DEI? And he says, America is changing. It's becoming much more diverse. And as we think about the last 18 months with the pandemic, US minorities are disproportionately affected by healthcare disparities. Increasingly, diversity in the healthcare professionals, particularly our surgical subspecialties, can have a major impact. For sure, leading a diverse surgical workforce will have better quality of care and will provide a much more conducive and better learning environment. It will increase creativity and innovation for everyone. And a more diverse workforce will lead us to providing better, more equitable, and more inclusive research questions. And of course, having diversity and inclusion will create a higher business performance with better outcomes and the creation of much better teams. And finally, I think the diversity and inclusion will create a better access to care for the underserved we all provide care for. And so to me, Dr. Eberlein really just summed it up, why DEI is so important. And so what are the strategies? How do we eliminate disparities within our workforce? So this is really a call to action to increase diversity, equity, inclusion, anti-racism, social justice, and allyship. And so this starts at the top. So the American College of Surgeons has been really committed to DEI and achieving health equity for all. They've created an Office of Diversity led by C. Armstead, who is the director, Dr. Bonnie Simpson-Mason, who is the medical director and an orthopedic surgeon by training. Their statement is they're committed, this is coming from the college, to taking strategic actions that really foster a diverse, equitable, and inclusive, trauma-informed culture that yields better outcomes for all staff members and patients that they serve. I have been fortunate enough to be the diversity pillar lead for the Board of Governors, and we are tackling a lot of these issues in our various work groups, particularly a toolkit that's going to be coming out very soon. It's going to be a comprehensive course that has a core content and fundamentals for DEI and anti-racism with actionable steps for everyone to be able to utilize. It's in partnership with the Division of Education, and it will be available digitally. Here are the editors for that toolkit, Dr. Infantum, Dr. Flores, Dr. Orlando Curtin, as well as Dr. Mason and C. Armstead. We are also very focused on this attrition issue of our trainees. We've created a task force where we're partnering with the ACT and all the important stakeholders in really getting a grasp on this issue and trying to eliminate it because it's a big problem. We are seeing a change in our journals. Dr. Melina Kibbe, Dr. Julie Freischlag really encouraged a call to action for all the editorial journals to really strive for diversity in the peer review process among the editorial boards and the editorial leaders. At the time, There was a pledge by nearly half of the editors to prioritize this. This is Dr. Wren, who published this groundbreaking paper of ensuring equity, diversity, inclusion in academic surgery. And from this was the white paper from the American Surgical. And since this time, we've now had a lot of DEI committees and task force surgical society. I'm chair of the AAST DEI committee for the Western, and I serve on the DEI committee for the Committee on Trauma. And so, we are really tackling a lot of these issues and prioritizing it, right? Because again, the focus is achieving really excellent outcomes for all of our patients. But the real goal is to integrate DEI within the fabric of every organization such that a committee is no longer needed. And so if you've been talked down, now we're down to institutions. What can institutions do? Having that framework. Every institution really should have a chief diversity officer who reports to the dean to strategize and implement a mission and initiatives for the School of Medicine. A Department of Surgery should have a vice chair of diversity who reports to the chair, really strategizing that mission and initiatives for the department, and having an equity council. It's very important. To advise, to implement initiatives, have mentoring committees, guide the department in URM faculty and leadership development programs, mentoring advancement of faculty across the department. And the Equity Council really is a representation of the entire department of leaders. So the chair, the division chiefs, faculty members, residents, fellows, that meets monthly and looking at the data. And Dr. Hannah Valentine was at the NIH and now she's here, but looking at metrics and looking and doing an annual evaluation of different demographics, diversity in your grand round speakers, looking at health equity as a domain of quality, and then looking at salary and really ensuring transparency, equity, and accountability. And we really focusing on health equity, right? Because you can't have quality without equity, and there's no equity without quality. And equity is really the forgotten domain of quality. It's part of the Vizient 6 domains, but you can see it's about 5%. And currently, it's not really tied to accreditation as of today. That will likely be changing because the Joint Commission, as of this year, has now mandated that we have dedicated leadership to implement strategies for reducing health disparities, and CMS payment determination will be tied to mandatory reporting of social determinants of health. And so we were able to have this conversation at the AAST meeting back in September. We're tackling a lot of the issues of health equity, the historical framework that got us to where we are, and what we can do now to institute a framework to be able to really look at health equity metrics. And we were focusing in on acute care, right? Because we're acute care surgeons, but you can replace acute care and put any specialty in there and begin looking at your own health equity metrics and really identifying what initiatives can we do to improve health equity. And Dr. Lisa Milton wrote this up, and it will be hopefully it will be coming out in Trauma Surgery and Acute Care Open soon. Salary, we got to talk about it, right? Because women surgeons face the largest disparity at about $2.5 million. There is a sex pay gap, and that male surgeon salaries are significantly higher than female surgeons' salaries, despite similar RVU production, with the greatest difference between male and female salaries was in paid appointed leadership positions. And so my question was, well, what about the pay gap among faculty with intersectional identities? And so, this is all about retaining your faculty. And so all of these things are very, very important. And I was able to really write about this, are institutions ready for diversity? And, the disparities really in the advancement to leadership, promotion, funding, pay parity, they're there. But it's incumbent upon institutions, hospitals, organizations, really to invest in diversity readiness by ensuring an equitable, supportive, inclusive, and psychologically safe environment, free from all forms of discrimination and bias, while simultaneously implementing accountability measures such that faculty, trainees, staff, and patients and their families are held to these standards. And diversity readiness really begins by creating an institutional DEI framework rooted in transparency and accountability. So here's a summary of the recommendations and solutions. Having a fundamental understanding of the importance of DEI in providing high quality, equitable healthcare for our patients, creating a psychologically safe workplace free from bias and microaggressions. Recognize microaggressions, whether you're the observer, the target, or the unintentional perpetrator of the microaggressions. Employ the strategies. We talked about grit, open the front door, action, XYZ, IQE, and respond. Strive to become an active ally and an upstander by not being silent when witnessing biases and microaggressions or overt racism. So remember, everyone can do something. And at this time in our history, particularly this time, it's even more important that we show up for one another as upstanders. And that research shows that even a knowing glance is traumatizing for the person who was targeted. And one of the most important things that we can do is to let the person who is targeted know in some way, however big or small, that they are not alone. And as Martin Luther King said in the end, we'll remember not the words of our enemies, but the silence of our friends. And so as the call for action at the individual level, educate yourselves about the history to understand why we are where we are today, and become an active ally. For the institution, increase the URIM pipeline and plug the leaks. So have a holistic approach to the general surgery residency applications to increase the pipeline. Clearly not an issue here, but this is a general issue. Climate survey of resident program and department. Ensure a zero tolerance policy for racism, bias, bullying, and discrimination. Education, so it's cultural, I should update my slide, cultural humility, not competency, anti-racist and implicit bias training, and intersectionality. Create a mechanism to report discrimination and implement a cultural complications curriculum if you already have one. For the institution, the Department of Surgery faculty and leaderships really should reflect the diversity of the people to whom they serve. Evaluating health equity as a measure of quality. So we actually, our diversity chair, vice chair, has implemented health equity metric goals as defined by the dean. So the dean of our institution is that every division needs to identify a health equity goal, measure it, and then put in an intervention. Add DEI roles as a valued metric for promotion. Be intentional in sponsoring, promoting, and advancing URIM faculty to leadership. Protect the URIM faculty from the minority tax. So, especially if you have so few, very difficult for the one or the two to be responsible for every DEI initiative within the institution. That takes them away from research or other things that they would like to do, and it's also even though you may be an underrepresented minority, you may not be fully versed on DEI. So understanding that it's everyone's in this together, and it's not just the underrepresented minority faculty or trainee that needs to sort of address these issues. So ensure leadership roles for URIM faculty are not limited to DEI positions. Avoid the glass cliff phenomenon, meaning promoting someone to a high risk role and not giving them the support. So if or when they fail, that's to be expected if they're not giving the support that they need. Adequate resources. Pay parity and pay equity, very important. Gender, race, and intersectional identities in achieving salary equity. And again, transparency and accountability in the DEI framework. And so, I just want to end this by, this came from the AAST. And, diversity really has been widely recognized as a key to excellence in academic medicine. and practicing conscious inclusion and equity mindedness to achieve inclusion excellence. In an environment where diversity is a strategic imperative. Inclusivity is intentional, exclusionary practices have been identified, critically deconstructed and eliminated, and that really will enable the bonuses of diversity to be revealed, actualized, and leveraged. Then and only then will a diverse workforce be empowered to attain full potential, and academic medical centers will be able to truly attain excellence.